Hello, I'm Tom Martin from the University of California, San Francisco, Helen Diller Family Comprehensive Cancer Center. And I'm joined today with Blood Cancers Today Editor-in-Chief, Dr. Sagar Lonial of the Winship Cancer Institute in Emory, Dr. Shambavi Richard of the Center of Excellence for Multiple Myeloma in the Icahn School of Medicine at Mount Sinai in New York, and Dr. Peter Voorhees of the Levine Cancer Institute in North Carolina. And this is our first roundtable of discussion on BCMA targeted CAR T cell therapy. So I want to branch off to toxicity. Once a patient gets infusion of CAR T cells, and our two products, they're a little bit different. So, ide-cel, we try to give between 300 and 450 million cells, whereas cilta-cel, patients are given somewhere between 40 and maybe 60 million cells, so a little lower. And there are some differences in toxicities too. So let's talk a little bit about CRS, or cytokine release syndrome. Those are, probably the most significant in terms of the incidence for toxicity after CAR T cell therapy. So, Peter, what have you seen with ide-cel and cilta-cel in terms of CRS?
So as far as the incidence, very similar. So in the ide-cel experience, the overall rate of cytokine release syndrome was 84%. When you look at grade 3 and higher, it was 5%. The overall rate of CRS with cilta-cel was a bit higher at 95%, but the rates of grade 3 and higher CRS was very similar at approximately 4%. The median duration of CRS was also very similar between the two products. It was 5 days with ide-cel. It was 4 days with cilta-cel. It's the timing of onset that's different. So the timing of onset with ide-cel is 1 day. So it happens early. And this may in part be due to the fact that you're giving a higher cell dose right from the get-go, whereas perhaps there needs to be some degree of expansion with cilta-cel before you start to see those CRS manifestations declare themselves. But with cilta-cel, the median onset is actually 7 days. So you have to keep that into consideration when you're constructing your algorithms for inpatient versus outpatient CAR T cell therapy, when to anticipate where things could go wrong. But thankfully, in the overwhelming majority of cases, both with ide-cel and cilta-cel, a manageable problem, with the majority being mild to moderate in severity. And tocilizumab was used in about half of the patients with ide-cel. It was used in about 70% of the patients with cilta-cel.
Interesting. Yeah. In San Francisco, because we have bridges, we make it it makes it challenging for us to do some of this as an outpatient. We will generally give LD chemo if we can as an outpatient, but once we start with the infusion, we do inpatient. But how about at your guys' center? Do you guys prefer to do one versus the other based on inpatient, outpatient strategies? Sagar, how about at Emory?
No, not necessarily. I don't think we're quite ready. We have a 24-hour ICC for cancer that will help us to do both CARs and bispecifics. We're not quite ready with the logistics yet, I think, to do them as outpatients.
Shambavi, how about in New York? Are you guys able to do anything outpatient or mostly inpatient?
No, we're doing them all inpatient. Our outpatient, the challenge is, again, the traffic and the pathway through our incredible emergency room system. So
exactly. And there's never a free bed. That's the hard part. Well, the other toxicity that's, of concern, and you've addressed it a little already, Shambavi, has been the neurologic toxicity. So can you just tell us about what your experience has been with ide-cel and cilta-cel in terms of the neurotoxicity?
Yeah, so so there's the ICANS, which is the typical neurotoxicity that we talk about that's in the setting of the CRS, can happen at the tail end of CRS, right after the CRS, any time point, but generally tends to happen in that first 2 weeks of their hospitalization most of the time. And that just seems to be pretty similar between the two groups. So 18% with the ide-cel, 16% with cilta-cel, and in terms of grade 3 and higher, both under 5%. So that seems to be more or less comparable. maybe not big differences there. But in terms of the delayed neurotoxicity, this is where there seems to be some differences, and we've seen delayed neurotoxicities with cilta-cel, not that much reported with the ide-cel. So in terms of the delayed neurotoxicity, there have been, or other neurotoxicities, and these seem to take various formats, initially called motor and neurocognitive syndromes, which has now been renamed because they really look more like Parkinsonian-like syndromes. And so with the cilta-cel, with the CARTITUDE-1, there were 6 patients who had this particular unusual kind of toxicity. And then 7 with other patients who had other kinds of neurotoxicities, which included things like cranial nerve palsies or peripheral neuropathies or sensory neuropathies and things like that. So these tended to be a little bit harder to manage. With the ICANS, easier to manage. With steroids, generally took care of it the majority of the time. But with the delayed, steroids didn't seem to be that effective. Most of the time it was supportive care and just watching and managing. But the Parkinsonian ones was significantly harder to manage. And in fact, there have been 3 deaths with patients who had that, 2 from sepsis related, 1 from just progression of Parkinson's that couldn't be controlled. 2, others that are either stable, not fully recovered, or slowly recovering or recovered. So, and what was seen with these were risk factors for these harder to manage and less understood delayed neurotoxicities was, 1, the grade of CRS. How quickly are you controlling the CRS? What was the disease burden? Higher disease burden, progressive disease at the time of CAR-T, any degree of ICANS, particularly higher grades of ICANS. All of these were risk factors for developing these. So with the CARTITUDE-2, these were mitigative strategies were set in place where, we're more aggressive with disease control. And one of the biggest changes that we made was early and aggressive management of CRS, regardless of now the kind of product that we use. Really don't wait for that grade 2 CRS before we start using our anti-IL-6 receptor antibodies and things like that. So we use Toci almost immediately with the first or second fever, especially if the fever is consistent, especially if it's higher grade. Then we do that. We try to control the disease as much as possible. And these have shown in the CARTITUDE-2 trials to reduce that risk from 5% to less than 1%. So I think we're on the right track with this. The others that are a little bit harder to control are high CAR T-cell expansion, exposure, and persistence, which seems to be somewhat arbitrary. We don't quite understand who gets those high expansion numbers. Is it always relatable to high disease burden, or do they happen independently? I think there's a lot we need to learn with all of that. But
yeah, it's a very interesting topic. In fact, we are also a believer of early intervention of CRS. We're a first fever group. The minute the person has first fever, it doesn't matter which product, what time, how many days after the CAR-T, we give tocilizumab with the first fever. And then if they have a second fever, we had steroids right away. So we are very aggressive too. Now, I'm just curious because your institution has published some data that BCMA maybe have some expression in the brain. Are you a believer that may be the etiology of the late neurotoxicity?
I think it's a very, very interesting question. So we did do, one of the patients who died with this was from our institution. We did a fairly extensive workup with that patient, including autopsy studies and things like that. And we did see BCMA at the basal ganglia, at the caudate nucleus on those autopsy studies. And looking at the database in the transcriptomics, this mRNA expression, BCMA expression has been seen. The problem is these are not very standardized, right, in terms of detecting these on tissue outside of the bone marrow. So I think that we need really a lot better studies on this, really focusing on this, looking at healthy brain, looking at, what happens with the CAR-T. We've done LPs and looked at CSF and these, and of course we see CAR-T cells in the CSF, but we know that with CRS or with ICANS or these, the blood-brain barrier is disrupted. So it's not unusual to find CAR-T cells anyway in the CSF. So I think there's a lot to learn from all of this. While the science is very interesting, we are still having to act on what to do with patients while these things are still going on. And, one of the other things that we have done, and there is preclinical data to support this, wherein monocyte and macrophage-derived IL-1 are big drivers of these kinds of more unusual, either refractory CRS or neurotoxicities or maybe even HLH. And so we use anakinra, anti-IL-1 receptor antibody, quite a lot. And sometimes it even becomes like our second line agent, wherein very quickly, if we are finding the ferritins are rising, we don't wait for those tens of thousands. If the ferritins are rapidly rising, if they have tripled or quadrupled, I just introduce the anakinra right away because it has pretty low toxicity. And, maybe it helps to mitigate all of these things. Maybe it helps to, even be steroid sparing. I tend to use steroids much less because, our patient, in fact, didn't respond with any of these maneuvers with the Parkinson's and got a lot of aggressive, cytotoxics to try to control this and ultimately died of an infection. So I think all of these are very real problems in our patients and things to look at. The other interesting thing with this is that when we did the dopamine uptake studies, they were negative. So I don't think they have the same pathology as regular Parkinson's patients, So I think it's Parkinson-like, but there's some differences. And, the easiest thing to blame is that there is BCMA expression in these cells, but I think we have to prove that better.
Yeah, it's very interesting. And it's very difficult to treat, as you had said, and they don't really respond as well to Parkinsonian, standard treatments, et cetera. Well, the other toxicity that actually occurs quite frequently, probably the most frequent, is cytopenias. So Sagar, what is your strategy at Emory in terms of treating cytopenias in people that have received CAR T-cell therapeutics?
Yeah, I think a lot of it really depends on the timing. Obviously, early you think about CRS related or LD chemo related cytopenias. Again, the bystander effect with all those dying myeloma cells in the marrow sometimes suppresses normal hematopoiesis, and it takes a little bit of time to recover from that. The one thing that I think you really do need to make sure is being checked early on is antiviral issues, and I think that really is critically important because certainly CMV, we've had one patient who dropped all of their counts and it was all related to CMV. So making sure that you do the appropriate infectious workup early on, a broad infectious workup. I think many of us do serial antiviral titers over time just to make sure, like you would in a post-allo transplant patient, monitoring, not necessarily intervening unless there are other signs or symptoms, but being aware of what's going on with things like CMV and potentially EBV. And then, when you get a few months out and you look in the marrow and there's no myeloma, but there's also not a lot of normal marrow, and you've gone through all the infectious issues and all the other things, that's when I think about giving a stem cell boost if I've got cells left over. And a lot of these patients, I do have cells left over. And ideally, if I'm going to do that, I want to do that in the first few months after the CAR infusion, because if there are contaminating tumor cells in the graft, then you feel a little bit better if they're circulating CARs. But if you're a year out and their CARs are gone, then you worry a little bit more about introducing something. But, I've had patients who I didn't have extra cells on, had a very empty marrow and were thrombocytopenic with platelets in the 3,000 and 4,000 range, for a year and a half after CAR. So I think it is something you got to pay attention to. I don't have any hesitation with growth factor across the board. So I think we all feel pretty comfortable using whether it's white cell, red cell, or platelet growth factors to try and make them transfusion independent.
And you can use those long-term, no problem.
Yeah.
Very good. And so you mentioned infections. I'll just briefly say with infections, there are periods of infections, just like after auto or allo transplant. There's the early period where patients actually develop neutropenia from the LD chemotherapy and from the CRS. We at UCSF, we use prophylaxis for that. We use bacterial and antifungal prophylaxis. And if patients have CRS, they do get therapies like tocilizumab and sometimes steroids. And so there is an incidence of bacterial infections and fungal infections during that period of time. If they have long-term neutropenia, we would consider, switching the antifungal from really a candidate, preventative to a more of a mold preventative therapeutic. But it's really also about the longer-term risk. And Peter mentioned this earlier, as they develop severe hypogammaglobulinemia that can sometimes last 6 months, 12 months, or even longer. And we do give IVIG support to patients, especially if they have a serum immunoglobulin G level of less than 400. They get serial IVIG to try to keep them above 400. patients are on VZV prophylaxis with acyclovir in our hands up for a year. And then we also use PJP prophylaxis with whatever therapeutic. We tend not to use the sulfa-based drugs just because it can cause cytopenias. So we use other drugs like atovaquone, et cetera. And those continue until their CD4 cell count gets greater than 200 essentially in our experience. And so if somebody does come in with a febrile episode, like you said, Sagar, you have to look for all the opportunistic viruses and infections. And so adenovirus, parvovirus, CMV reactivation, hepatitis B reactivation, you need to look at all those things depending on the clinical scenario, which is really important.